look at the thread on our, please take a look at our SHAAP account. That's at SHAAP Alcohol, and hopefully Chloe or someone else will pop that in the chat. Thank you. And we'll be using the hashtag ALCOC 2020. So that's ALCOCC 22. Everyone's going to be muted except for our speakers. And as we go along, please do post any questions or comments in the chat. And we usually have a really good discussion after the seminar. So today I'm really delighted to welcome Dr. Amy Chandler and Annie Taylor. They're going to be presenting on the topic, Navigating the Complexity of Harm and Care, a qualitative study of self-harm and alcohol use. And I think the conjunction of alcohol and mental health is such an important one. It comes up on all the research projects that we work on. So I'm really looking forward to hearing more about that. So Dr. Amy Chandler is a senior lecturer at the University of Edinburgh, where she leads sociological and interdisciplinary research on suicide, self-harm and substance use. She specialises in qualitative methodologies with a focus on understanding the relationships between personal accounts and experiences and wider social, cultural and political contexts. Welcome, Amy. Annie Taylor is a PhD researcher at Edinburgh and Napier University, focusing on the social context of alcohol and pregnancy. Annie has worked in policy, practice and research spanning health, social care and education for over a decade. She's been involved in various research studies across the public, academic and third sectors with a focus on children and families. And Annie's research interests include gender, maternity, health inequalities and alcohol and drug use. So I'm delighted now to hand over to Amy and Annie to talk about their fascinating work. Thank you both.
Thanks, Carol, and thanks to SHAAP and SARN for letting us come along and speak to you all in this presentation. I'm just going to try and share my screen now, and then we'll get started. Hang on. Okay, hopefully that is all visible.
Yeah, thank you.
Okay, so again, thanks so much for having us. So we're going to be speaking about a small piece of pilot research or exploratory research that we did last year in the midst of a pandemic, in the midst of lots of lockdowns, yeah. This is a project that we're still working on, we're still thinking with, and so we're really looking forward to hopefully a really good discussion with you all once we've shared some of the outlines of what we did. So before I get started properly, a quick note about the project funding and how it came to be. The project was funded by Alcohol Change UK / Alcohol Change Cymru, and Alcohol Change commissioned this research as a consultancy project because they were interested in knowing more about how people understood the relationships between self-harm and alcohol use. It was something that was coming up a lot in their own work around kind of policy, practice, research. And so they wanted some qualitative research that would look at this in more detail. So they had some role in the design of the project. They'd asked for a qualitative research and the research questions, but they didn't play any role in the analysis or write-up, though they have supported the dissemination of the findings. Annie and I don't have any conflicts of interest, and we're both currently now working at the University of Edinburgh. So when Annie was working on the project with me last year, she was in the process of finishing up her PhD at Edinburgh Napier, but now she's a research fellow at the University of Edinburgh Murray House. So that's good. Very good indeed. So alcohol and self-harm are connected and have been understood to be connected in multiple ways for some time. They are often framed as being kind of statistically understood to kind of be correlated. So there's an excellent study by Ness and colleagues from 2015, which looked at hospital presentations for self-harm and found that over half of these involved alcohol use. And again, numerous studies that look at hospital presentations for self-harm, which we might define as self-injury or self-poisoning, irrespective of the apparent purpose of the act. So this isn't necessarily looking at suicide attempts, although often it's very difficult to kind of disentangle the motivations that we're talking about here. So in terms of hospital presentations, alcohol use is often involved. alcohol use at presentation, Ness and colleagues found, was associated with those patients being more likely to repeat self-harm or more likely to be kind of admitted to hospital with a repeated self-harm, and indeed was associated with increased risk of later mortality, whether by suicide or other means. Other studies have looked more specifically at suicide and alcohol misuse, and again have found that these things are correlated. And as such, across a lot of kind of policy documents, self-harm and alcohol use, especially in combination, are kind of prioritised as being an area of particular concern, there's a particular need about how services respond to this group. However, despite a lot of work identifying these sort of statistical correlations between self-harm and alcohol use, and indeed some experimental studies that have attempted to explore this, these studies often tend to look at alcohol and self-harm in relatively simplistic or straightforward ways as having a fairly unproblematic causal relationship. So alcohol is assumed to lower inhibitions, to be associated with social and relational problems, which themselves are also risk factors for suicide or self-harm. Or alcohol is framed as acting as a chemical depressant, further enhancing the mental illness or depression that is often assumed to drive self-harm and suicide. However, this kind of approach sits fairly uneasily with decades of research in the social sciences, which have underlined the contingent nature of and effects of alcohol consumption. So David Moore and colleagues, who some of you will probably know their work fairly well, addressed this in their study of the relationship between violence and alcohol use. In their study, they were particularly looking at the use of the phrase alcohol-fueled violence in kind of public and policy representations of alcohol-related harm. They argue that this term frames the relationship between alcohol and violence as being directly causal, in spite of extensive and long-standing anthropological, sociological, and historical research which shows the effects of alcohol and other drugs, including violence, and I would add to that self-harm and suicide, as being contingent on historical, social, and political contexts. However, much existing research that's looking at alcohol and self-harm has not really engaged with these sort of social, cultural, or indeed political contexts. And so it's in this context that when Alcohol Change approached me about this consultancy, I was, interested in doing this. And this built on previous work that I'd done looking at the relationship between alcohol and self-harm among men who were, again, understood to be at particularly high risk of harms from both of these. So the project that we engaged in was looking at how people make sense of self-harm and alcohol use when they are engaged in both of these. We were testing assumptions, trying to kind of challenge some of these more simplistic and straightforward understandings of a relationship between self-harm and alcohol use, and explore the way in which this kind of played out in the accounts that people who had these experiences, how they talked about them. So the approach that we took was, as I said, a qualitative one, and we held semi-structured interviews with 11 people across England and Wales who self-identified as having experience of both self-harm and alcohol use. In the way that we kind of recruited for this project, we were deliberately broad in terms of how we defined self-harm and alcohol use. We were interested in how people themselves would define each of these practices. We weren't narrowly focused on people, for instance, who had alcohol dependence or would classify themselves as misusing alcohol. We were interested in kind of exploring more generally the relationship between self-harm and alcohol use that may or may not be dependent or kind of officially problematic. Similarly with self-harm, we left a very broad definition of that. So we were, as a result of that, we had a diverse sample. Although it was a small one, it was incredibly diverse in terms of the histories of self-harm and alcohol use that people reported. So we spoke with 5 men and 6 women aged from their early 20s through to their mid-50s. All but one participant had white British ethnicity, and all but one participant was cisgendered. All of the interviews were done online or by the phone, on the phone. This was in the midst of a pandemic, and that was what we did. And they were 1 hour each, which was pretty challenging, to be honest, in terms of the complexity of some of the accounts that we got. It really felt like more time was needed, and that's a definite limitation of this project. So in the interviews, participants were asked to provide accounts about their experiences across their own life course of self-harm, of alcohol use, their reflections on the relationships between the two, and then they were directly asked to reflect on their experiences with services in the context of thinking about their experiences with self-harm and self-harm and alcohol use. So the analysis was directed primarily by Annie. I did the interviews, Annie did the analysis, and then we kind of collaborated towards the end of that. The analysis itself was informed by narrative approaches, and indeed the way that the interviews progressed was narrative in nature, in that we were interested in the stories and accounts participants were providing about these things. Although we asked them to talk about their experiences, we're very conscious that the context of a research interview provides particular types of accounts and telling. And so we really kind of maintained a view on that in our analysis. So in a second, I'm going to pass over to Annie, who's going to talk you through an overview of some of our findings. Now, as I said, we're still continuing to work with the analysis of these findings. We're working on ongoing publications. So this is a kind of whistle-stop tour of some key issues that we've kind of generated in our analysis, but we're really keen to hear from you all any comments or suggestions or thoughts you might have in terms of these. So our findings are split into three kind of subsections. Annie's going to speak through some of the parallels between self-harm and alcohol use that emerged in some of the accounts we heard, before turning to the connections that we might draw between self-harm and alcohol use. And then Annie will pass over to me and I'll discuss some of the service responses to self-harm and alcohol use. So that is the end of my bit now, and I'll pass over to Annie.
Thanks, Amy. So the first of the key findings sections really is about the parallels between participants' accounts of self-harm and their accounts of alcohol use. So the parallels related to the meanings that each practice had for individuals, as well as the responses that they recounted from others towards both alcohol and self-harm. So the first kind of parallel that came through in the accounts was about hiding and secrecy. There was a crucial difference between self-harm and alcohol in terms of the accounts from participants, in how far each practice was seen as socially acceptable or normalised. So alcohol use was routinely described as being a normal part of everyday life. That might not be surprising to a lot of people here. Holding important social functions, but self-harm was clearly marked as more pathological and secretive. But while self-harm across the sample was framed as something that participants kept really carefully hidden, for many of those who described dependent or problematic drinking practices, this too became hidden. So for some participants, this happened at a relatively early stage of their life. For example, Seth in his 20s and Luther in his 30s. Indicated a sort of swift move to secret drinking in their teens that carried on for a number of years. So there's a key parallel then in the way that practices of self-harm and, for some people, problematic drinking were kept hidden. Considering why people might keep self-harm and problematic alcohol use hidden is really important. It might often be suggested that each of those is associated with shame and stigma, but among our participants, we heard stories that demonstrated some of the ways that that shame and stigma was enacted or exacerbated by social responses. Millie, for example, was in her 20s, and she described a long history of self-harm starting in her teens and problematic alcohol use that developed in her late teens, particularly binge drinking. And she described that as leading to her being in dangerous situations. So here she indicated that when her self-harm was initially noticed by her mother, the response was threatening, leading Millie to take more care when she was hiding her self-harm in future, and hiding the associated distress that she was experiencing. This wasn't an uncommon story. Several of the participants, mostly women in their 20s or 30s, described experiences where either parents or schools reacted in unsupportive or dismissive ways when they encountered self-harm. Seth, also in his 20s, shared a recent experience of requesting notes from mental health services, reporting on treatment that he received when he was a teenager, and discovered that services attributed his problems to family relationships rather than the homophobic bullying that Seth associated more strongly with the self-harm that he'd experienced. For some participants, like I said earlier, alcohol use was also hidden in secret. Luther was in recovery for alcohol dependence in his 30s, described a long-standing engagement in drinking that became secretive early on in his teens, with a recognition that both his parents and other circles of friends wouldn't approve of his use of alcohol. For other participants, though, alcohol use was more embedded in social relationships. For example, for Luther, alcohol could sometimes early on take on a similar hidden nature. So sometimes it could be social and sometimes it could be hidden. So those accounts underline the inherently social nature, shame and stigma, participants' maintenance of secrecy around either self-harm or alcohol use, or sometimes both, was tied in their stories to dismissive or punitive social contexts. Participants talked about active, methods of coping. So another strong parallel in how participants talked about their use of self-harm and alcohol was the role of each or both as a form of coping with stress, with social situations, with difficult relationships, or with strong feelings. David, who was in his 50s and in recovery for alcohol dependence, reflected on his early use of alcohol relating to difficulty managing in social situations. Alcohol helped him to cope in such instances. Several other participants also referred to using alcohol as a way of coping with difficult social situations, with alcohol helping to ease social interactions. Seth, though, provided quite a different account, describing both his self-harm and his alcohol use as methods of coping with difficult times. For Seth, drinking was a less serious coping method than self-harm. And Seth also separated out his social drinking from drinking to cope drinking. Drinking socially and drinking alone were framed in different ways and served completely different purposes. Though only a few participants explicitly framed self-harm as a way of coping, a common way in which self-harm was described related it directly to difficulties. So self-harm was something participants said they did more or started at times of difficulty, tying their practice of self-harm to particular instances of challenge. What these difficulties were ranged widely and were usually multiple, including feelings of sadness and overwhelm, self-loathing, experiences of childhood abuse or being in prison, among other things. A final prominent parallel in how participants talked about alcohol and self-harm was that drinking and self-harm were often described in relation to being in and out of control. Accounts often emphasise the tension between feeling in and out of control, involved in both drinking and self-harm. Jane, who identified her self-harm as controlling food and taking sexual risks, said that those two types of self-harm served different purposes for her, being in control through food and out of control through sex, though she related both to feelings of self-loathing and low self-worth. Similarly, Leon, in his 30s and in recovery for alcohol dependence, reflected on self-harm as a way of being in control and simultaneously out of control, and as both healing and harmful. In contrast, other participants referred to self-harm as a response to feeling out of control, a way of responding to such overwhelming feelings. Francesca, for instance, who described a long history of alcohol and drug use as well as self-harm, described each of these in relation to feeling out of control. Alcohol could exacerbate feelings of being out of control, and self-harm was something she did in response to situations where she felt out of control, often but not always while she was drunk, and her emotions became overwhelming. Alongside the multiple parallels we identified in how participants talked about self-harm and alcohol use, we also identified a number of complex connections. These included that alcohol was understood to exacerbate self-harm in different ways, mirroring assumptions in much of the existing literature. But beyond this, participants discussed other more surprising ways in which their self-harm and alcohol use were entwined. The first of these connections is about exacerbation. So several participants identified that self-harm for them had been more severe or more common at times when they were also drinking. Brenda was in her 20s and described a period of many years where she used both self-harm and alcohol, with the two practices becoming more entwined over time. Cutting herself when drunk became almost habitual, resulting in increasingly severe injuries. It was a recognition of the relationship between the two that led gradually to an attempt to disentangle the relationship. Other participants, such as Millie, also identified that when drinking alcohol, self-harm was so much worse. And like a number of other participants, injuries from self-harm were described as more severe, with more likelihood of visits to A&E and stitches. For other participants, the feelings that alcohol use magnified were understood as exacerbating urges or desires to self-harm. Some framed this around lowering inhibitions and increasing risk-taking. In contrast, though, for Jane in her 30s, and who described her self-harm in terms of restricted eating and forms of sexual self-harm, suggested that alcohol use contributed to the feelings of self-loathing and guilt that then fed into further self-harm. For those participants who described self-harm and alcohol use as forms of coping, the relationship between the two was sometimes framed in terms of replacement. Seth, in his 20s, suggested that currently he used drinking in a controlled but regular manner as a way of avoiding self-harm. Drinking, like self-harm for some of the other participants, was framed by Seth as a way of processing and letting out emotions. Without this release, Seth suggested he might use other less healthy, or he was calling them less healthy, coping methods. Seth also noticed that he was better able to hide alcohol use than hiding self-harm. Recounting a recent experience of visiting relatives, struggling and experiencing urges to self-harm via cutting, he chose to drink instead because that was more easily hidden or absorbed into normal social life. Francesca, in her 30s, also alluded to using self-harm when alcohol was unavailable, discussing how her practices of self-harm increased dramatically while she was in residential rehabilitation to stop her drinking. So some participants used the interviews to directly explore the parallels in how self-harm and alcohol were understood as ways of coping, and to reflect on the ways that they had, whether consciously or unconsciously, used one in place of the other. While some participants defined self-harm and drinking as separate but connected, others framed drinking as a form of self-harm. So David, in his 50s, and with experience of both dependent drinking and several overdoses, which he framed explicitly as suicide attempts, suggested that his most recent drinking, prior to his current abstinence, was, in his view, self-harm. David's conception of drinking as self-harm may have reflected his experience of services and the strong recovery-based narrative that shaped his account. He was really deeply involved in recovery movements, had been in residential rehab, and was currently living in a dry house. So abstinence and seeing alcohol as harmful were quite key aspects of his account. Similarly, Luther, in his 30s, described long-term and ongoing engagement in a range of different practices that he called self-harm. This included heavy and sustained drinking, but also extended to engaging in risky physical sports, deliberately putting himself in harm's way, often whilst drinking. Alcohol had become for Luther the most dominant and far-reaching form of self-harm, with both physical and social repercussions, and that led to him accessing support to stop drinking. I'm going to pass back over to Amy now to talk about some of our findings around accessing services and care.
Thanks, Annie. Right, hang on. Okay, great. So as Annie says, in the final section of our findings, I'm going to discuss some of the challenging experience that participants described in accessing services when they had issues with both self-harm and alcohol use. Okay, so several participants described experiencing significant challenges in accessing services that were able to respond well to both their self-harm and to their alcohol use. So Francesca, for instance, described being rejected from particular forms of mental health support because she was drinking regularly. Like many participants, she described trying numerous avenues over really quite long periods of time, trying both addictions and mental health services, before eventually landing with a key worker in an addiction service as it happened, who was able to help her. Francesca suggested that she had been previously told that as she was using alcohol whilst trying to seek mental health support, that her low moods, her feelings of depression were not real. She said they said it wasn't a real mood, so they couldn't diagnose me with anything. They couldn't put me on anything. And, you know, she said here, they suggested that she could come back later when she was sober and then they would be able to see her. So an understanding or fear that services would not respond well to a disclosure of either alcohol use when trying to access mental health services or self-harm when accessing alcohol services led many participants to indicate that they just simply did not tell the whole story when they were accessing one or the other service. Jane, for instance, was a practitioner as well as a service user, like several of our participants. And she was clear that the services that she wanted to access in the local area that she lived in would certainly not see her and not offer her support for mental health if she also disclosed alcohol use. So she suggested that thankfully for her, her issues with alcohol were not one of dependence. It was, what she described as binge drinking. But she was very kind of articulate and reflective on the relationships between her alcohol use and her self-harm, but didn't feel able to disclose that alcohol use when seeking support for her mental health issues, despite feeling they were really deeply entwined. In contrast, Leon suggested that he was scared to disclose his self-harm to his alcohol support service. Luther similarly indicated a clear sense that there was absolutely no way on earth that he would discuss his experiences with self-harm with the alcohol services that he was engaging with. Now, although this was a small sample, one possible area that I think would need to further reflection and further study to check in on is whether or not there is a gendered issue here, because the men that we spoke to certainly seemed less likely to feel comfortable disclosing self-harm, which may be something relates something to the gendered connotations of self-harm being seen as something that is more often practiced by women or girls, despite that not really being the case. So the challenges that participants described in accessing mental health or addictions or alcohol services indicated something of a challenge with complexity. So David, who we've heard about previously, was in his 50s, in recovery from alcohol dependence, and had described a really long engagement with various forms of self-harm. So we'd mentioned suicide attempts. David also had described cutting as well. And he suggested that he had been turned away from mental health services in the past due to his ongoing alcohol use, again, paralleling the stories from several other participants who had similar experiences. He now held a view that his addiction to alcohol itself should be seen as a mental health issue. And he reflected that if services perhaps could approach the addiction or his addiction in this way, then the full complexity of his problems might have been better responded to. Instead, despite much help seeking across his life and indeed help receiving, often with police involvement, David didn't receive effective support until his mid-50s and continued to struggle with mental health issues, although officially was enrolled in addiction services. So as you can see from the quote here, he says, my belief is that my addiction to alcohol was so strong, I class it as a mental illness. There shouldn't be a line, it should all be under one banner. But that certainly hadn't been his experience at that point. So Millie, who was in her 20s and again reported a long history of self-harm, suicidal thoughts and alcohol use, was currently, when I spoke with her at the start of last year, on a long waiting list to be seen by a psychologist. Similarly, Jane had described being rejected on, similarly to Millie, who was kind of told that she couldn't access IAPs or kind of short-term psychological therapy because her problems were too complex and too long-standing. She was then therefore put on this longer-term waiting list for a psychologist. And Millie reflected with me during the interview that the kind of absurdity of this, that part of the reason she was referred to longer term therapy was because of the acute suicidal thoughts and feelings that she was having, as well as ongoing self-harm. She says, you tell someone that you want to kill yourself and you have to wait to July. And I spoke with Millie in February. So this is, she was still at this, had a long way ahead of her and was struggling. Similarly, Jane described being rejected on other occasions due to her problems also being framed as long-standing and multiple. She said, I had the assessments and they would say, well, your issues are just too long-standing for us to be able to support you. We're a short-term service. So another way that complexity was referred to was especially common among women, all but one of whom had a diagnosis, or crucially, a suspected diagnosis of what's called borderline or unstable personality disorder. For several participants, the suspected nature of their diagnosis, which might have been indicated by one service but then wasn't confirmed by another, meant that accessing support for what they saw as potentially a really significant diagnostic label for their complex experiences meant that they weren't able to access, for instance, DBT or dialectic behavioural therapy, which is seen as a useful support for those with that diagnosis. And they were therefore left with very limited recourse to services that they felt could help them. And again, this sort of tied up with the general sense across the participants that we spoke with, that services struggled to kind of to manage the complexity of their differing issues across addictions and mental health. So another common finding, not just of our study, but across multiple studies and decades of research which have looked at both self-harm and alcohol use, is that each of these can be associated with poor treatment, perhaps especially in clinical settings that are acute, such as A&E. And where there may be competing narratives that self-harm and alcohol use each constitute potential disorder or a potential treatable issue, but also kind of really quite surprisingly resilient attitudes that both of these may be understood as self-inflicted, and, you know, with self-harm often understood as also associated with attention seeking, which is not a good thing. It is pejorative. So we were especially interested in this study to try and examine responses from services for participants where both self-harm and alcohol use were in evidence. So for instance, especially when people were presenting at A&E with self-harm, having also been using alcohol. So as expected, many participants did report negative responses from services, particularly though certainly not only in A&E settings. However, with this small study and with these limited interviews, it was difficult to disentangle how far negative responses might be attributed to the combination of self-harm and alcohol use. Although, as Rachel reflected on her kind of broad experiences with these services, I tend to find that they're a lot sharper if I've been drinking. She suggested there's not an awful lot of empathy there. Brenda, who noted that she had only ever attended A&E for self-harm when she'd been drinking, reported a familiar, to me at least, story of being dismissed by staff and told that her problems were invented. Further, several participants reported sharing, in a less acute manner, sharing ongoing distress and suicidal ideation with services and nothing really happening. They described kind of plucking up the courage to go to a general practitioner or other service to report, especially feelings of suicidal ideation or self-harm, and being placed on a long waiting list or prescribed antidepressants with no further treatment offered. Francesca, in the final quote that I've put here, suggested that she was only really taken seriously if she had actually harmed herself. She said, if I'm low and depressed and I feel like crap and I don't want to live anymore, they don't really bother with you. But if you self-harm or take an overdose, they will bother with you. Apologies. So this really speaks to kind of a central tension in terms of how self-harm in particular is understood and responded to. Acts are taken more seriously in this space than thoughts or feelings are, resulting in the rather perverse outcome that people may feel that they're not cared for or supported unless they harm themselves. Now, this finding is not at all specific to those with alcohol use issues, but given the other problems that participants experienced with being or feeling too complex for many other forms of services or support, it may indicate a kind of deeper issue for those who are sharing those experiences where this, existing tension is exacerbated. So across the interviews, participants spoke of limited opportunities to explore or discuss self-harm and alcohol use. They described being silenced or dismissed. Questions about one or the other of these practices were often not asked if a service was dedicated to either self-harm and mental health or to alcohol and addiction. Participants frequently talked about these questions just not being asked, people not being asked if they were experiencing issues with alcohol, not being asked if self-harm was an issue for them. Jade, who again was another one of our participants who was also a practitioner, worked as an addiction support worker, as well as having her own history with self-harm and addictions. And she discussed drawing on these experiences to inform her own approach, but was clear that this had not been her own experience. So now Jade suggested, if I saw a woman coming in who had self-harmed, I'd be sitting with her and asking about it. She wouldn't just ignore it, which had been her own experience. And she reflected, see if just one person had sat down with me and asked me about it. But for Jade, nobody had. Other participants also indicated that if they had been asked directly about self-harm in alcohol use treatment or alcohol use in mental health treatment that they may have disclosed and felt able to talk about it, but that crucially these questions just tended not to be asked. Accessibility of services was another key issue for many participants. Most described multiple attempts to seek help from NHS and from third sector services, from helplines and websites. Family and friends were notably absent for most participants as a source of support or care. Most described really difficult relationships with family and friends, and really this wasn't a space where they could access support, meaning that reliance on service was important, but again, not often there. Inaccessibility of services exacerbated participants' distress and increased potentially their risk. And they reflected quite explicitly on this. Long waiting times, rejected referrals, and limited options all made things very difficult. And for some participants, as per Francesca's quote on the last slide, help was only accessible after serious or life-threatening events, such as a suicide attempt, or for some participants being in prison or police custody had been the kind of turning point that they felt they needed. But participants reflected on what might have been if they had been offered or been able to access help before these crises. And this underlines the importance of services perhaps being needs-led rather than focused on particular diagnoses or thresholds of risk. Perhaps unsurprisingly, participants who had experienced positive support underlined the importance of good relationships and positive, encouraging support from individual practitioners, often over many years. And I'm sure that for many of you, this will be completely unsurprising. While Leon asserted that such care couldn't happen out of thin air, so he talked about this particular worker who'd really just sort of stayed with him, and he said, you know, something like that, though it's just down to the person, you can't expect a service to just provide people like that. However, I think it's also clear that the service design, the caseloads, the values and ethos of an organisation will all impact on whether the provision of such care is encouraged or indeed even possible. So, in conclusion, some messages from services that we were able to draw out of the interviews about the way that responses to self-harm and alcohol use could meet the needs of those whose experiences involve a number of issues. Services should be able to respond to needs and not exclude people on the basis of apparent complexity. Services should not be designed in such a way that complex experiences are silenced. Neither self-harm, perhaps in particular, but or alcohol use should be minimised if individuals are, reporting to services and highlighting concerns or problems with them. A number of, participants across, all of this, their variety experience being told that their problems were not really important enough for them to reach the threshold for referral to this or that service, or that there just wasn't any support there for their particular problems. Care should be taken, not to make assumptions about what either self-harm means or what alcohol means and what the relationship between the two may be. As the kind of earlier part of the findings suggested, there is a huge amount of complexity in terms of participants' own understandings about the relationships between the two. There were no straightforward answers here. So we found that most, but not all, participants would have appreciated being asked about a wide array of their experiences when seeking support from either addictions or mental health services, giving them permission to share and discuss these. That said, there were also clear gaps reported in terms of different kind of practitioners' understanding and knowledge about self-harm among addictions workers, or about the potential roles of alcohol use in self-harm among mental health workers. Although crucially, there were exceptions to this, where participants often, after a long search, were able to find a service or an individual worker who could support them across all of their issues. So in conclusion, then, we really found that participants were advocating for needs-based services rather than diagnosis-based services. But these were a small sample of participants, a huge amount of diversity within that. But I think one of the kind of overwhelming kind of things that we perhaps would find from these accounts is the need for further reflection on these. The sample was pretty limited in terms of what we were able to do in the time that we had. And I think that there will be an even wider diversity of experiences across different bits of the country and different kind of communities that were not represented in our sample. So we really look forward to hearing thoughts and questions and comments from you all. As I said, this is an ongoing project for us both. So Annie and I will pass over to you. Thank you very much.
Thank you so much, Amy and Annie. There's so much in your presentation, just kind of trying to think through it. I'm sure everyone's feeling the same way, but really such an important issue and such rich data that you've got from it. I wonder if I can start off by asking a little bit about your decisions about going for the sample that you did, and also how you recruited them.
Yep, good question. So we recruited through there was a bit of a journey with this project. So originally it was commissioned by Alcohol Change Cymru, and they were particularly interested in the Welsh context. So the project actually initially started pre-pandemic, and I was supposed to be travelling down to Wales to spend time with services that kind of supported those who used alcohol or self-harm, to kind of really start to explore that with individuals in those spaces. And then pandemic hit, we had to do a big kind of key change in terms of the approach that we were going to use. So we worked through mental health services and addiction services and put the call out to them, and that's how the recruitment happened in support services in England and Wales. And ultimately we kind of took whoever came forward. We were expecting that this would perhaps be a challenging topic, and again, particularly given some of those issues that we then discovered about people not disclosing about self-harm when they were in treatment for alcohol use, or not disclosing alcohol use when they're in treatment for mental health. So I think, actually that was news. Like, I hadn't really been kind of really fully conscious of that. So I think that likely affected the type of sample that we got. But we got a really good response initially. We had a very short period of time to do this. It ended up being a really, really short piece of consultancy. So we could certainly have got a larger and more diverse sample if we'd have had more time to do it. And by the end, we were turning people away because we had kind of reached our limit of my capacity during lockdown. So.
Thank you. And when you were saying about the hour and you needed more time, why did you stick to the hour? Was that what the participants had been told?
Yes. So it was about kind of, this was my first experience of doing interviews online. And I was kind of really conscious of people's energy and the kind of the sensitivity of the topics that we were dealing with. And just the big ask that it is really to sort of, come into this relationship and do this. And the sort of the short time frame that we had really kind of limited that. It was really insufficient. Participants were incredibly reflective, and I think given more time and space, we would have been able to kind of dig further into some of these experiences and and views that they had. It was about capacity, resource that we had available, how much money we had for transcription. All of these things played into it, unfortunately. So.
Yeah, I think all these pragmatic concerns are so important and can't be ignored when we're thinking about research. I also wonder, just in terms of characterising the sample and not in any way imposing definitions on your respondents, if you had an idea about the range of drinking in the sample, because you talked about some people being alcohol dependent, but no,
absolutely. So there were, I'm trying to think off the top of my head without going through the final report and the demographics, but we also kind of avoided describing the sample in too much detail, given how small it was, and that actually some of the intricacies of some of these experiences probably potentially undermine anonymity and confidentiality. But we had a kind of a sort of subset of participants who described kind of clinically treated alcohol dependence, and I would say that would probably be about a third of the sample. And then a third of the sample probably would describe kind of binge drinking that was never seen by any kind of clinical service or diagnosed or responded to in a clinical treatment. And they were often participants who also carried diagnoses of borderline personality disorder. And then a kind of mixture of other people who described just a kind of much more diverse kind of range of I'm thinking more about self-harm, but yes, it was kind of that spectrum, I think, of like from binge drinking, and particularly binge drinking and experiencing kind of social and interpersonal upsets and harms, as well as being like experiencing physical harms as well. So through to much longer term alcohol dependence. So it was a big spectrum, I think, in a very small sample. So.
Thank you. I've got many other questions to ask, but I'm going to go to some of the other questions. And there's a lot of comments in the chat, but I guess what I'm really looking for is particular questions about the research or about the policy implications or about people's experience as practitioners or as researchers. Marion Rackett comments that this is important and invaluable and should be widely disseminated to mental health services and addiction services. Marion, I just wondered if you were coming from a practitioner point of view or a researcher point of view there, if you wanted to add anything.
Yes, hello. Sorry about that. Thank you so much. It was an excellent presentation. And I'm a practitioner for many, many years, and I've never heard a presentation like that before, highlighting all the individual factors that are affecting each person who presents. And we experience the same difficulties here in Ireland between mental health and addiction services. And honestly, one of the things I feel very strongly about is the absence of training to deal with this. I mean, we have psychologists, we have social workers, OTs and so on, but there's very little specific, really in-depth detail in dealing with, all of the consequences of self-harm and so on, and addiction. So I do think that this, we need lots more research like this, and the case histories, I know there was only 11, but look, this is a great start, and it's wonderful for helplines, and certainly we'll be listening to it very carefully again for our helpline in terms of what the research has been saying. So thank you both so much for an excellent presentation.
Thanks.
Thank you, Marion. Eleanor, did you want to come in and ask your question, please?
Yes, I was just interested, and I guess because since I've been at SHAAP, I do feel this is just this ongoing issue that comes up all the time, is whether it's people's own personal experiences or from the perspective of healthcare professionals or whoever it may be, that people do feel that if they've got a significant mental health problem or diagnosed mental illness, and an alcohol addiction or some sort of problem relating to alcohol consumption, that they will be signposted to one service, but because of their diagnosis or other issue, then they get bounced to the other service, and basically neither service will see them from that sort of holistic perspective. And I guess it's something that we all seem aware of, and is totally brought to bear in your research, that this is something that just continually happens to the people here. And you made some recommendations which I think are really helpful, but I wonder what you think are the barriers as to why we all sort of seem to know this, but still we have this situation where people who have got an alcohol problem and a mental health problem somehow don't seem to be able to access a service that joins the two together.
That's a very good question. I'm not sure that, I don't know, Annie, if you've had any thoughts, and please just jump in if you do. But yeah, I think, I mean, obviously probably a lot to do is to do with just how these things have been framed, I guess, historically as separate. And I think I would probably defer to other people on this call that would probably know more about why that's happened, because I think, when we started trying to look at some of the wider literature, especially around kind of services and why this separation existed, which, as you say, Eleanor, is widely acknowledged as a problem and as a thing that is there. So I'm not entirely sure why that is the case.
Sorry, Amy. I think there's possibly also something about funding as well, which is obviously to do with the historical, the history and the way that things have been constructed in the past. But a few of the participants in this small project did talk about funding, and it's something that I've seen, and I'm sure lots of people on this call have seen coming up in various places, about the way that things are funded can really affect, what those services are able to do, and also possibly something about diagnosis too. So if we're relying on a kind of diagnosis of any kind, whether it's to do with alcohol or to do with mental health or to do with anything else, then that can make it difficult to then have a kind of diverse, holistic way of looking at things. And it's, you know, what kept coming up in this was about being needs-led, so offering needs-led support, and that doesn't always fit perfectly with a diagnosis-led service, even though practitioners want to be able to respond to need.
I think I would just add as well, just in terms of that, I guess, is that in terms of self-harm in general, this is something that people, you know, so a lot of my previous work, although some of it's touched on alcohol use, self-harm, a lot of it has just been focused on self-harm alone. And this issue of sort of diagnosis and gatekeeping of services around that is something that people who self-harm have faced a lot, because they're often seen as not having a mental health, you know, a diagnosable mental health condition, and therefore struggle to get access to services. So I think there's that issue as well. And so that when alcohol and self-harm are combined here, there's that additional exacerbation. Diane, I can see you said you can't find your hand and you've got a copy.
Yeah, I'm so sorry. I don't know why. Yeah, I'd just like to make a couple of comments. And I find it so interesting why people who have alcohol issues self-harm. And to my way of thinking, and this is just my thoughts, yeah, one's already been mentioned that your self-image is really low, and so it doesn't really matter in a way if you self-harm yourself. But I think the other thing I think of that's possibly true is that it's a sort of self-punishment. Maybe at some level you recognize that you're hurting people who care for you, and just maybe there's nothing you can do about it because you can't stop drinking, I just wonder if that's taken into account by people who see people at services, you know, whether they understand. Certainly I think that's yeah, as I've said, and I did say I'm a patient in recovery because I wanted people to know that the comments I made were coming from somebody who does have an alcohol issue. I think it would help me if people that I saw did understand that maybe I was punishing myself because of what I'm doing to other people. And I don't know if that's true, but it's something I think that should be thought about.
Thanks, Diane. Yeah, no, that's a really pertinent comment. And it's certainly something, the kind of ideas and themes around sort of self-punishment and that kind of sort of were alluded to in some of the slides, particularly Jane's account was quite strong on this, but not just Jane's at all, around the idea of both self-harm and alcohol use being kind of tied up with self-punishment. And I think, you know, what you've described there around, you know, potential punishment for harms done to other that are caused by the alcohol use, I think it just adds that additional layer of how that can kind of play out for both of these things. Absolutely. So yeah, no, I think there are a number. I mean, I think one of the key things we found from just speaking to this small group of people was just how diverse people's accounts of why they had self-harmed, why they used alcohol were, but absolutely for some sort of self-punishment was a key part of it. And indeed for some people who self-harm, there's that sense that by harming yourself you are harming those around you. You know, and that can again be an important part for some people of a recognition of a need to move away from that. But at the same time, there's those, you know, again, one of those parallels around kind of urges and desires to continue using, or whether that's self-harm or alcohol use, can make that really tricky.
Yeah.
So, yeah, thanks so much for that.
Thank you.
Thank you. I think this work is really important for people who work in services as well, Amy and Annie. When we did our work with LGBTQ plus people who'd used alcohol services, we talked to the LGBTQ plus people, and we also talked to the practitioners. And quite often the practitioners, and one of our findings was that LGBTQ plus identity was often, but not always, very much bound up in relationships with alcohol, and that mental health played a factor in that as well. But sometimes the practitioners felt they were being intrusive by asking about sexuality or gender identity, and if it was important, the patient would bring it up, or they felt that they didn't have training and they might do more harm than good. So sometimes I think it's important if we can get to a position where we're trying to help practitioners. I think sometimes practitioners feel like we're just saying you're doing this wrong and you're doing this wrong, you know, and how can and sometimes it's constraints, as we've alluded to, about the way that services are set up or about funding. So I don't know if there's service providers who would like to make a comment about that. I know that Jenna Leggett is here, who's a student nurse. Jen, is there anything that you would like to talk about in relationship to addiction services and mental health issues?
Hi.
Hi.
So I saw Eleanor's question, and that was one of the first questions I asked on my last placement, which was in the addiction services. Because my placement before that had been a community mental health team that was really integrated. They had meetings every single day where one person from each service was together to discuss the referrals or anything that had come in. And it seems it is being tried in majority of the NHS services in Scotland, but it's just not effective in them all. And when I asked my last placement why it wasn't combined there, and it was simply because it just didn't work, the communication was really poor. So I think a lot of it is down to education and acceptance as well, that it is one problem that needs dealt with. But I think it's just one of those things that's going to take time and perseverance.
Thank you, Jenna. And I think obviously one thing we could do straight away in terms of training is around the issues that you were highlighting in your presentation around people saying, oh, it's a waste, you're wasting my time, that's attention seeking. I mean, that seems to be a really important bit of education to be doing.
It is indeed. It's a bit of education that should have, well, it's, you know, these kinds of stories and accounts have been being told for over 30 years, probably more. But yeah, I mean, it's clearly, I mean, I think one of the challenges is that, you know, some of the kind of, you know, and again, I'm aware that we did focus a lot on the negatives in terms of services, and it can feel a bit like, you know, a bit damning. And there were good stories told, but I think some of these issues with the kind of attitudes that practitioners have around, you know, self-harm and also alcohol use, you know, again, many of you will be totally aware of this, but it's, you know, it's not just about their training and the services that they work in. It's also about wider social attitudes towards these practices. You know, these kind of stigmatizing attitudes don't come from nowhere. You know, they are kind of supported in a lot of ways by assumptions that many people hold about health and illness and how people should keep themselves well and what that means if they're not, or if they're actively or seem to actively harm themselves. So I think, you know, there's a bigger piece there, as well as staff training and kind of to acknowledge the context that staff are having to work in. So, yeah.
Thank you. We've also got a comment from Mark Sweeney, who is linking sort of population level policies to what you've been talking about today. So Mark, would you like to ask your question?
Hi, yeah, so I am a pharmacist independent prescriber with a particular interest in the treatment of addiction, who's based in England. And one of the things which is quite disparate between all of the devolved nations is the governmental policy on alcohol pricing. I know Scotland have implemented minimum unit pricing, as is Wales, and there's talks about it in Northern Ireland. I was wondering if in your research, Amy, you'd found if any of the participants had noticed an impact of minimum unit pricing on their alcohol use.
I'm afraid it's a very short answer to that question. No, that's not something that we explicitly asked about, and it's not something that anybody brought up. But again, these were really short interviews, you know, so the section where we were asking, you know, about these different things, it didn't, yeah, there wasn't necessarily space for us to ask specifically about that, but it would be, I think it's an interesting one to think about in terms of the impacts of those sort of national level policies, not only on alcohol use, but absolutely on kind of, you know, other issues such as, well, with self-harm, the main measurement tends to be hospital treated self-harm, which, you know, I think there are some, you know, interesting relationships there. A lot of the existing statistical knowledge is focused on that context. but far less is known about kind of more general population kind of rates of self-harm and how that might be related with alcohol use. And so again, that would be another really interesting question to ask, I think, in terms of the impact of national level policies on wider harms as well as alcohol use. So it's a really good point, but unfortunately not one I can really give much info on.
No worries. Well, thanks, Amy. Great presentation as well.
Thanks, Mark. And you may already be aware of this, but there's a couple of months ago, there was a presentation looking at the impact of minimum unit pricing on vulnerable groups, specifically homeless drinkers in Scotland. And that report's now on the SHAAP website as well. And maybe Chloe will drop that in the chat for us as well. I wonder if we can go over to Andy Parkinson now, please, who's a manager of 2 supported accommodation projects. Would you like to ask your question, Andy?
Thank you. It wasn't really a question, Carol. It was more of an observation. I think, I manage, 2 supported accommodation projects for people experiencing homelessness in Sheffield. And we have, 68 beds for men and women. We see a lot of clients who have issues around comorbidity, where they're either drinking or using drugs to cope with underlying mental health issues. And you can't, get services to work collaboratively around the 2 issues would maybe be a better way of putting it. And, I think, to a certain extent, we are fortunate in homelessness services because of the prevalence of rough sleeping in the media, that there are now an increase, there seems to be pocketed funding around outreach and inreach for rough sleepers and people, which means there's a bit more crossover perhaps between the 2 than there was previously. However, thinking about the general population, groups that aren't maybe seen as marginalized, even though people are marginalized. I think one of the issues is there's political issues around contracts and funding and who's responsible for what. There's also issues around just a disconnect between policymakers and frontline staff, and they don't understand that there can be someone living in a service like ours who is drinking themselves to death, and they can't just stop because they're drinking to self-medicate or because they're trying to cope with this underlying trauma. And, there's such a fear and anxiety around stopping because then they have to deal with the overriding emotions. So I just wanted to acknowledge, I think, as the conversation's already been held, that this isn't a new issue. It's not a quick issue to fix, I think, but I think this research is really encouraging because hopefully more projects like this will highlight the fact that more work needs to be done and that understanding needs to be moved up the chain, so to speak. So thank you for the stuff that's been shared today. And I'm not sure what everybody else thinks of what I've said, but I hope that captures the spirit of my comments.
Thank you, Andy. Yeah, no, it's really it's encouraging to hear that the small bit of work that we've done is resonating. But absolutely, in terms of this being a well-established area that needs kind of more work, is there's lots to be done. There's lots to be done. But yeah, if this is a small part of that, then that is good. I think this disconnect between different forms of services and how they're able within something like homelessness services to kind of, that collaboration can happen, but they're just I think, again, given the diversity of the participants that we spoke to, some of them had been in, homelessness type services or kind of more kind of supported wraparound care, but most were kind of really on the edges of all of that. And so we're just bouncing between different services with nobody really supporting them in a lot of cases. So yeah, there is definitely room for more.
Thanks, Andy. I think that's really helpful when you have these kind of different areas where you can take learning and kind of move it sideways. I think there's been some really great work with homeless populations, for example, in Canada with managed alcohol problems, which have really low thresholds, so that rather than expecting people to turn up sober to one service or not to have all these other, to sort out all their other problems, they could have take people where they are and try and help them at that point. And I think you know, some of the things that you've been discussing in your talk today, that you need to take people where they are rather than expecting them either to hide part of what's happening in their lives or to magically, you know, lose some of the issues that they've got. I think that's really helpful. Here from Kath Jeffers here, working in Bolton, Bury, Salford and Trafford. Kath, would you like to come on and ask your question or make your comment, please?
I was probably just hearing kind of what everyone says, kind of in terms of where they feel like individuals are being shunted from one service to another. And I am seeing developments. I work for Greater Manchester Mental Health Trust. I think we're in a fortunate position, which is very rare, that our addiction services is still under the NHS. So I think within the 3 areas, kind of Bolton, Salford and Trafford, actually our IAPT and therapy services, also our mental health services and addiction services are all commissioned kind of within kind of the Greater Manchester Mental Health Trust. And because of that, there's been at a strategic level a buy-in where we actually have a co-occurring conditions policy, and there's an expectation for us all to come together for co-occurring conditions meetings to kind of review kind of our pathways, because, you know, we shouldn't have separate dual diagnosis teams by any means, but, you know, I think, you know, statistics have shown those accessing addiction services, 80% will identify they've had adverse childhood experiences, you know, trauma, identify mental health issues. So it means we need to get kind of better at kind of enabling people to access our services, you know, so we can support people instead of kind of bouncing between you don't meet our threshold, because we cannot guarantee someone's safety by asking or requesting that, you know, they're completely abstinent from substances so they can engage in therapy, which has made us kind of review our therapy. We have psychologists on board now, and we have to make it, you know, it's gender specific, you know, it's trauma informed to enable people to access the help at the right time. And it's about, I know it's a culture shift, but I think in terms of the developments in terms of the CMHT transformation plans and the new mental health framework, you know, it's envisaged that we're going to be moving away from that siloed, hard to reach services to kind of more joined up care and whole population approaches. And especially when we're seeing kind of in terms of the developments of our primary care networks, our integrated care systems, and, you know, and hopefully, you know, you know, in time we're going to start being able to support individuals at the right time instead of it kind of crisis management.
Thank you, Kath. Amy or Annie, do you want to add anything or respond?
Just that I think absolutely, you know, it's good to hear that things are slowly starting to move in what could be the right direction. I think, you know, it was just so clear from the participants that we spoke to that services in general were not able to respond unless there was a crisis. So I think, you know, that we've got these kind of policy moves towards kind of reorganizing services so that they may be more able to do that. You know, because I mean, partly because reducing distress is lovely, but also, you know, in terms of cost effectiveness, it surely makes more sense to engage with somebody before they're at crisis point. But yeah, so it's all good to hear. Thank you.
Thank you. I'm going to ask a question, but if there's anyone else that wants to stick up their hand and ask anything, and Eleanor can help me with spotting any hands, please do. So Amy, you kind of alluded to the fact it's obviously a small sample, but there might be some issues with gender going on. And of course, we have expectations as a society of what self-harm means and who we expect to self-harm and who we expect to have problems with drinking. Do you think that's something that could or should be researched in more detail in the future? That's a bit of a leading question, isn't it? What are your thoughts more generally on gender and your research topic?
Thank you, Carol. Yeah, no, it is. I mean, and also I'm a researcher, so it's like at the end of every project, I'm like, well, yeah, there's a lot more that could be done here. I mean, and certainly, I mean, so some of my past work has looked more explicitly at masculinity and self-harm and alcohol use. And so, I mean, with this, even within this very small samples, I think, you know, you could probably identify potential gendered patterns that could be examined more, you know, more carefully. I think one of the things in terms of my broader work on self-harm, and this project has sort of reaffirmed it, is that although men are understood in a lot of kind of community surveys of self-harm to not report self-harm as often as women, in interviews they often also suggest that they wouldn't disclose self-harm, you know, and another issue which was actually across men and women in our small sample is that the types of self-harm they were reported were not necessarily those that you would really identify in an accident and emergency kind of admission, or indeed necessarily to be picked up in a kind of survey. So I think there's a huge amount of complexity in terms of how self-harm is understood, and those kinds of then really complicated relationships that might occur when you're adding substance use, whether that's alcohol use or other drugs to the mix as well, both in terms of the meanings that they have, and also, you know, the kind of the outcomes of those practices too. So I think, you know, it would be really interesting to explore that with bigger samples. It'd be great if surveys could ask better questions about self-harm that were more inclusive and allowed you to kind of tease out some of those differences. I mean, so one of the challenges in a lot of self-harm research is that a very broad definition of self-harm is used to look at rates, and that is self-injury or self-poisoning, irrespective of the apparent purpose of the act. You know, and across all of my work on self-harm, there's a huge diversity of methods of self-harm, which can have very different meanings for people. So I think it would be, yeah, that would be a kind of key thing. And then to look at patterns across gender, you know, so the men that we spoke to in this sample did describe practices of sort of self-injury and self-cutting, but were perhaps more likely to describe suicide attempts. And, you know, so there's a lot to unpick there. So yes, Carol, more research would be good. Yeah.
Excellent, thank you. And I also wondered, and I don't know, Annie, if you want to pick this up, in the narratives that people were conveying to you, I don't know if you had a chance within the time limit to ask about sort of initiation. So when people were learning to drink, or and also around learning to self-harm, I was wondering if these were intertwined in any way. And also I thought it was really interesting the way you were talking about hiding or not hiding. In our LGBTQ plus work, some of our respondents felt that they'd already, you know, gone through the difficulties for many of them of coming out as LGBTQ, and now they had to come out as someone who had problems with alcohol. Did any of your respondents feel that, well, you know, I've had to talk about problems with alcohol and now I have to talk about problems with self-harm, you know, that's another stigmatizing identity that I need to talk about, and the difficulties around that? Sorry, that's two questions.
No, it's fine. Yeah, people did talk about when they started drinking. Quite a lot of the participants what sort of recalled that seemed to remember quite clearly the first time that either the first time that they drank or the first time that they got the feeling of being drunk, and some of them recalled that in quite a lot of detail. And people did talk about, I think, their initial experience of self-harm and the kind of trajectory that they'd gone through over a number of years with both drinking and self-harm, and how that changed over time sometimes, and how the ways in which the two practices interacted with each other changed over time as well. Sometimes, I mean, it was different, obviously, for each of the participants, but some did talk about drinking early on and that being hidden because it was so early, but then, you know, because they were so young, but then later on it becoming less hidden as it became more more socially acceptable to be drinking heavily, or seen to be drinking heavily, or seen to be binge drinking, and that would be, you know, that's more acceptable as they get older. So the hiding thing kind of changed over time as well. And in terms of your second question, I don't know, Amy might have something to add to this, but people were talking a lot about the complexity of both drinking and self-harming, and how they were intertwined, and the hiding thing really came through when they were talking about how to access support. And I know we've talked about a lot about that this afternoon, but I think the idea of sort of coming out in terms of self-harm and coming out in terms of drinking, it would depend on who you were talking to. And I think people talk about that in terms of all different kinds of coming out. And yeah, that is something that came through about being sort of out in some ways to some people, but not to others.
Yeah, no, I think I absolutely just echo that really. Yeah, people definitely, I think did fear. I think the burden of both the stigma of being, you know, understood to have dependent drinking, and or particularly self-harm as well was, you know, and again, as I said, it seemed particularly for some of the participants who were men, it's was seen as like you know, they were most, you know, quite a lot of the in fact, the four of the men we spoke to, they were, you know, were in alcohol treatment for alcohol dependency. And I think the idea of kind of then disclosing self-harm being an additional stigma is that could well be, you know, a part of it would be something to look at. And I think, you know, what Annie mentioned there about the trajectories and the different ways that alcohol and self-harm kind of appeared across the live courses were just, yeah, I think that's one of the things that we might work on in terms of future publications, because it was just so much diversity, and just looking at those patterns and how then that, you know, services might need to be like, could be perhaps more conscious of self-harm at different points. So for instance, when somebody's becoming abstinent from alcohol, for a number of participants, self-harm was something that really kicked up then. So there's lots. Yeah.
And then that feeds back into also the thing about stigma and being minimized and disapproved of. You know, the participant that I mentioned earlier on, who had been in residential services for her alcohol use and was then self-harming a lot, then she talked about the kind of disapproval from staff. And it seemed to, I mean, but we don't know, I guess, because this is such, you know, this was a small study and we didn't have a long time to talk to participants, but yeah, I think there's potential there for the kind of, yeah, to think about what happens next once. So she stopped drinking, then she was self-harming, and then she can't stay there because she's self-harming, but there's nothing else to support her. So it's kind of how they all link together, and the impact there of the responses from staff, and whether that comes from a place of not knowing what to do, you know, not knowing how to support somebody.
Thank you. Yes. Neil Wilson's got a question about uniformity or variation across areas. Neil.
Thank you. Yeah, I'm just concerned basically that in particular areas, the one I'm mostly involved with will remain nameless, provision is of generally a poor quality. I think that would be reasonable to say. And I wonder if it needs, I don't like the idea of having a regulator for everything, but I think in some cases it probably is a useful thing, and to provide a blueprint for how dual diagnosis and multi teams should be able to work together. Allied to that, I think there is also in some areas a bias against particular groups, and what am I meaning by that is people who appear to have their coping mechanisms, as in family and friend support, and therefore services don't respond perhaps in the way they should, because they don't appear to be the more extreme cases that they're facing elsewhere. So I apologise, 2 questions in one, but it's basically, is there bias, and do we need a regulator to essentially even things out across the country to provide a good framework? And I just wonder what the researchers thought to those couple of points, if that's okay. Thank you.
Good questions. Annie, I'll let you come in. I'm just going to do a very quick response. about the universal and regulation, I don't know, but yes, I think in terms of your kind of observation about services being poor in some areas, I mean, obviously this was a tiny study, we only looked at some areas which will have to remain nameless, but certainly that there seem to be some huge issues there. I think what would be really interesting to look at would be, and which others maybe already have done, is whether there are good, whether things are done better, and I think Kath's point earlier perhaps points to that. And in terms of a bias against certain groups, Annie, you'll probably reaffirm this, I think absolutely. We had some of, a significant, not in a statistical sense, group of our participants who were functioning well. They were holding down jobs, they were attending university or whatever, or school, they were getting okay results, and they were therefore deemed to be, very low threshold. I mean, one of the things with that, I think, that was very interesting is that we were speaking to people in their 20s who perhaps had then continued to struggle and not had any support at the time they were struggling, but seemed to be functioning, and they're, then experiencing kind of declines in their mental health, their use of alcohol, reaching crisis, that kind of thing. So I think that bias against people who seem to have everything in place, can then, backfire. And as I said, one of the kind of key things actually among this small sample was that family and friend support seemed to be pretty limited, actually. Annie, I don't know if you've got anything to add there.
Yeah, no, just to say that I agree, and that some of the participants did allude to the idea that because they were holding things down, they were managing, they were sort of could be looked at from the outside as coping. The support wasn't there for them. So they did a couple of people did allude to the idea that things might have to get worse then. And that's really quite disturbing. So yeah, I think these are good questions. I also don't have an answer to your question about whether we need a regulator, sorry, but I think it's an interesting question and something to think about. Yeah.
Thank you very much. Thank you so much to our presenters, Annie Taylor and Amy Chandler today. It was such a really important and fascinating topic. And thank you also for all the input from the audience and the discussion and the comments. At SHAAP and SARN, we think these links between alcohol and mental health are so important that our topic next month as well is about co-occurring heavy alcohol use and depression. And so the next session is on the 21st of June with Dr. Kat Jackson and Dr. Amy O'Donnell. But now to finish off, I would like those who can please to unmute, and let's give our audience, even though we're online, let's give our presenters a big round of applause. Thank you so much.
Thank you.